doing research. I was in my doctoral program, and it took a lot for me to really kind of find anything that had any substance to it. So what I saw, what I was dealing with mainly was just a lot of my own clinical experience, what we were seeing here, what other therapists were seeing here. And so we realized that this was something that we needed to address. We needed to address in a concurrent way rather than doing what a lot of people were doing up until that point, which was going to substance use treatment and then going to eating disorder treatment. So, okay. So when I was doing some research, I came across this quote, and this is from around 2003 or even maybe a little bit after that, but basically showing the link. So the link between substance use, abuse, and eating disorders sends a signal to parents, teachers, and health professionals that where you see the smoke of eating disorders, look for the fire of substance abuse, and vice versa. And that's exactly what we were seeing. And what was happening was I was seeing a lot of patients who didn't want to acknowledge that. Even if they had or were starting to have any kind of urges, they didn't want to deal with substance abuse stuff. They just wanted to focus on their eating disorder and continue on through treatment. But coming to see that that wasn't going to be sufficient to amount to any kind of really remarkable recovery. So here are some of the objectives that we're going to go over today. We'll talk about. I'm going to review some of the most common eating disorders and some of the criteria. I'm going to go over just some of the other, some of the other DSM-5 eating disorders as well. We're going to talk about how to learn how to differentiate between the most common eating disorders and some others that are now things that we are seeing with a lot of times with substance use disorders that can get a little confusing. I'll speak more to that too. And then we will learn about a lot of the co-occurring diagnoses, including substance use and persistent mental health diagnoses. We'll learn some medical complications associated with eating disorder treatments and co-occurring disorders, and be introduced to the integrated care model here at Montecatini and what that looks like on how we treat eating disorders and substance use. Let me just make sure I don't have anybody in the waiting room. I can't really see. Okay. All right. So I know that from what I know from you guys, I know that we've got some therapists here. We've got people here that treat substance use, other types of mental health disorders, some people that may have some interactions with eating disorders. And so I'm hoping that a lot of these points will be relative and helpful for you guys in your practice or dealing with some of the folks that you're seeing. And again, like Emily said, please feel free to put questions or comments into the chat bar so we can have a dialogue while we're going through the presentation. So what we do know and what is commonly known is that eating disorders are not just a behavioral health issue. They are a serious medical issue. And when they co-occur with substance use, you can imagine. So say, for instance, you get somebody with anorexia and they already have a lot of medical issues. Maybe they have like some cardiovascular issues. And then perhaps they start, snorting cocaine or doing meth. And they've already got this underlying issue cardiac-wise. And then you add in this amphetamine or this or cocaine, and what that can do to the cardiac system can be deadly. And unfortunately, a lot of deaths do come about because of that actual scenario that I just mentioned. So you take somebody who's got a very compromised immune system, and then you add in substances, and it can just make matters that much worse. Also, knowing that drug use can intensify the eating disorder behaviors. So meaning that when we have people, we see people all the time who come in and it's changing in a lot of ways where they find, they're finding new drugs, anything that could potentially affect, help, aid in their eating disorder in some way. For instance, like I mentioned, cocaine and meth, those are two common ones. But even a lot of what we're seeing and coming across now is more marijuana use and things like that. And what we often have are patients who are coming in and saying, you know, I'm smoking marijuana, but that's helping me with my eating disorder because I don't want to eat, I don't have any hunger cues, but when I'm smoking, I start feeling this sense of hunger. So I really need the marijuana because that will just help me feel more, have more hunger cues, but also help reduce anxiety. Unfortunately, though, that drug is also masking a lot of other things that are going on, and potentially some very important medical issues that may be happening that are reasons for the person not having the hunger cues, or more eating disorder types of behaviors that now are confused or confounded with the drug use. And just kind of like what we're saying, eating disorder can be camouflaged by the drug use. So a lot of times, you guys know, if there's somebody who's coming in who's been doing meth or cocaine, there's a good chance they may be underweight, or they may have not been eating. And that is something that we would all commonly expect that would be what would be going on with them. But if they do have an eating disorder, if they are anorexic, that can easily get overlooked because people may be focusing on the fact that, well, that's not eating, not having any hunger is part of the side effects from some of the drugs, cocaine, meth, that type of thing. So that's something that is also important, really important to look out for. And just overall, when we have the two, substance use and eating disorder at the same time, it gets more complicated. All of it does. Like, how do we assess? How do we differentiate? And how do we treat? All right. Okay, so I'm sure a lot of you are already familiar with this. I'm just going to run through some of the DSM-5 diagnoses for eating disorder. Some things have changed in the DSM-5. So primarily anorexia nervosa is categorized as restriction of energy intake relative to the requirements, leading to a significantly low body weight of the context of age, sex, developmental trajectory, and physical health. There's an intense fear of gaining weight. And then there's this real strong disturbance in how people can see themselves, see their body weight, and a very big detachment from what's real and what their perception is. Okay, next one, bulimia nervosa. So this is categorized of having two important factors. One is going to be the binging part of it, which has to be part of the bulimia nervosa diagnosis. And then the second is going to be a compensatory behavior. So that can either be through vomiting, it can be through laxatives, exercise, or fasting. And so there are times too with anorexia where we can see we have anorexia purging type. And so there's a difference in how we look at the diagnoses between bulimia and anorexia with purging type. And that's going to be that piece about the binging that becomes the factor that categorizes somebody as bulimic. Okay, and then binge eating disorder. So somewhat similar to bulimia, except there is no compensatory behavior, so no purging, just a lot of binging. And like you can see here, things are eating more rapidly, eating more volume of food within a discrete amount of time, and then also having these incredible feelings of shame and guilt, and feeling very guilty, but the behavior continues. Okay, is there any questions on any of those things? Any of those? Okay. Okay, so now here are a few of the other eating disorder diagnoses that can get a little complicated. So these are things that aren't typically, we don't see a lot of in our treatment. A lot of these disorders are treated on an outpatient basis, or sometimes they have to be, there are times where people need to be hospitalized. So one is pica. We do see this actually co-occur with anorexia. So that's really just the persistent eating of non-food items. It can be a lot of different things. And it's also has to do a lot of times just with other types of mental disorders. Typically people that are on the autism spectrum, other people that have intellectual or learning disabilities, or just other types of genetic issues that prevent them from really having the ability to discern or understand the non-nutritious types of items that are not food. And so let me give you an example. So we've had, one of the questions we ask, hold on one second, let me look a couple people in really quickly. Let me see how I can do that. Hold on. Okay, sorry about that. All right, so let me give you a couple examples. So one of the questions that we have on our assessment here at Monogatini, so when people are trying and interested in coming in, we will ask them, do you eat any type of non-food items? And a lot of times the answer is yes. A lot of times what we see are people who do not want to eat, they don't want to eat food, so they decide to eat cotton balls or paper or other types of things that will make them full or feel full that actually don't have any types of calories. And they do that in attempt to not have to eat food or calories. So that's a little bit different from the actual diagnosis of pica, but it does often co-occur with anorexia. And then there's rumination disorder, which essentially is repeated regurgitation. And so this again can be part of an eating disorder too. It's not necessarily attributed to any kind of GI problem, but there will be people that will chew food, regurgitate it, and then either spit it out or swallow it. And that can also be part of an eating disorder behavior too. So you eat it, you get some of the taste, but you don't want the calories, so you spit it out. So that does happen with some of our patients with primary diagnosis of anorexia, bulimia, or binge eating disorder. Okay. Okay, well, there we go. All right, a couple other things. There's something called ARFID. This is becoming a lot more prevalent. We see this a lot more. And I'm assuming that maybe you guys are probably seeing some of these things too in your own practices if you're working in private practice. Sometimes it's really hard, and you'll have folks who will say, I don't have an eating disorder. It's, I just have a problem with the taste of food or the texture of food. And there's, that's becoming something that is getting harder and harder to differentiate, even for eating disorder professionals, because a lot of times we'll have people come in and say, it's not that I care about the calories, I just don't like the texture of mushrooms, or this tastes so slimy, I can't eat it. And then all of a sudden, before you know it, there's a list of food exceptions. And, I can't eat this, I can't eat this. One more look there. Okay. All right. So I'm switching between screens here. So having a little, there we go. All right. And then just quickly, these are some of the other specified feeding and eating disorders. Atypical anorexia is basically when you meet all the criteria for anorexia, except that the weight loss or the individual's weight is not in an abnormal or low range. So you can see people who have anorexia who are at a normal body weight and sometimes even at a higher body weight. It really comes down to the types of behaviors and the restricting. Same thing with this bulimia, just different frequency and duration, and then purging disorder. And another thing too, I think that can get even more complicated. So when you start seeing some of these types of other specified eating disorders with people who have substance use, it's, again, it could be easy to say, well, you know what, I don't think this is really an eating disorder. I think this is more of just part of their detox or part of their rehabilitation, you know, and coming off of substances, but not necessarily an actual eating disorder. You know, it can be normal. You know, I know a lot of times we have people who come here who have been in substance use treatment, or they've been working in outpatient settings on their substance use. And part of what they're doing is they're changing their diet. They are doing a lot of exercise. And then before you know it, we get calls of people who have been running nonstop, or people who are now binging. I stopped drinking, I stopped using, and now I'm just binging and I can't stop. And I have this craving, you know, for sugar. And now, since I'm not using or drinking anymore, I'm running all the time. And then somebody's had this incredible amount of weight loss. Now that happens a lot. And I think as practitioners and for people who are in the field, it can be easy just to see that as, okay, maybe that's a normal reaction and response to not using and drinking. But that can also be something that is either falling into that OSFED category or potentially becoming a primary eating disorder, and things that we all need to be really aware of and looking out for. Okay. So these are some of the connections. And you know, what's really amazing is that more and more since the beginning, when I started really looking at this and I started seeing a lot of my patients who were struggling, there's been so much more research. There's been so many more people out there who are treating. And there's been a lot of research into the best ways to treat. And even despite everything that we've learned since, say, 2003, essentially all of the information, all of the recommendations are basically the same. And what we do know, what we've always known, is that people flip-flop. They want to have, you know, they're stopped using their eating disorder. And all of a sudden it's like, okay, now what do I do? You know, I don't have this eating disorder behavior, but I've got all of these emotions and this anxiety that is so high. I can't stand to be in my own skin. And then all of a sudden, you know, maybe just even innocently, I'm gonna go out to dinner, spend some time, just have a few drinks socially. And before you know it, it's the same reaction in the brain. There's this whole process that takes place. And just the, you know, idea or the thought of just drinking socially, all of a sudden, one person can start feeling as though my anxiety's better. I'm sort of used to, and it can be a very unconscious thing. But this is what happens, and this is why we see so many people who have eating disorders develop substance use disorders, and vice versa. Okay. It becomes this whole, there you go, the whack-a-mole game, right? It's, you know, when you think about what is underneath eating disorders, substance use, all of these types of behaviors, all of these addictions, you know, what drives it? There's a lot of factors, we know, and there's a lot of shared factors in both of these. So, but one of the things that is real is that trying to get rid of one and not use something else is a huge challenge. What we see here in Monocytini is we see a lot of different cross addiction, people going from one addiction to another, but it's all for the same reason. It's all to not feel the feelings that were driving eating disorder behaviors or substance use. It's to manage the effects and anxiety and depression maybe associated with trauma. It's feeling so uncomfortable in your own skin that you need something to change how you feel 24 hours a day, 7 days a week, because that feeling of just being yourself is so incredibly intolerable. So let me give you a few case examples of some of the folks that I've worked with over the years that I've been here. And these are some of the people that originally came in that were bringing some real attention to this situation, and it also informed the way I changed my treatment with the patients I started treating patients with substance use and eating disorder. So these are all these are names of these folks. But so, for instance, we had a young lady who came in, and she was about 20. She was 23 years old at the time. The first time she came in, and she had anorexia, and she had a lot of alcohol. She had never been diagnosed with any alcohol abuse. She had never considered that she had a problem with alcohol. But regardless of that, she had times that she could recall where she'd go out, she drank, do things, she would have more risky behavior and things like that when she was drinking. But she just completely chalked it up to, well, I'm young, I'm 23, this is normal, this is what I do. I was in college. And so all of that with this real focus of, I need to do something about my eating disorder. Unfortunately, she had done a lot of damage over time, having some cardiac issues, a lot of other lab abnormalities, which is really common. But she would not acknowledge that she had any problems with alcohol. Unfortunately, all of the drinking that she had been doing was affecting her liver value. So even though she was saying it's just eating disorder, there's a lot of commonality. So drugs and alcohol affect a lot of the same organ systems, obviously, that eating disorders do. So one of which is, of course, the liver. And we see patients who come in who have liver enzymes can be much worse and at a much more dangerous level than obviously somebody without that. Now, it's common. A lot of times people go about their normal life. They don't notice these things. These things aren't something that they're getting checked. But unfortunately, it can happen where you start really seeing the consequences and the medical complications happen, and before you actually are aware of any diagnosis of some sort of, because eating disorders also have a big effect on the liver. So with Donna, she came here 3 times. Firm was not willing to look at her eating, her substance use at all. She would not acknowledge it was a problem. She completely defended it. And there was a lot of denial. So it's a lot of what we see with other types of disorders, especially substance use disorders. Eating disorder. And she started feeling better. And I hadn't been working on that stuff in her treatment. She would have gone out and drank, and without even considering how that could be a problem, or considering that maybe this is going to become a problem because I'm not active in my eating disorder. So I'll get back to her in a little bit as we go through and give you a little bit more information on what the rest of her treatment looked like and how she ended up faring after going through treatment with us 3 times. And then I had a patient I'm calling Emma. She was 22 years old. She came in with bulimia, and she had substance use disorder, but she had gone to substance use treatment prior to coming into us. And she came in, she had been using cocaine, alcohol, a lot of other types of drugs. She was trying to manage her weight, which is something that we see a lot of. She didn't have hunger cues, so she had lost a lot of weight. She didn't, her metabolism was going really fast. So after she got her substances under control, she came in She was feeling good about where she was in terms of substance use. But what had been happening before she came to us was her bulimic behaviors just got out of control. So she started binging and purging so much. And then her suicidal ideation got really high. And then her self-harm behaviors at the same time too were really starting to surface. So here she was gaining weight. It was a normal, response to the fact that she wasn't using drugs and not eating. It got to the point where it was so overwhelming for her, she started cutting her abdomen, trying to cut parts of her body out that were so frustrating to her. So, and the reason why I'm mentioning her case was that in her mind, I think the severity of how bad her anxiety, of how bad her self-perception was, became such a huge part of her inability to stay sober or to even get through any type of eating disorder treatment. And so we see a lot of times where the self-harm behaviors and suicidal ideation are so strong and so prevalent. So we're trying to manage, people with their eating disorders, substance use, and then all these other things too. And so for Emma, she ended up, coming in, she did well. She was able to start turning the corner. She reduced her bulimic behaviors. But then it came to a point where she started thinking, you know what, maybe my substance use stuff wasn't that bad. Maybe I really didn't have a problem. And then ended up experimenting to see, did I really have a problem? Did I not have a problem? And that's kind of the course of what her treatment looked like. And then the last one is somebody I'm calling Kathy, and she was a 34-year-old with bulimia nervosa. And she used to drink socially. She would go out to dinner with her husband and have a drink. But when she started getting when she started improving from her bulimic behaviors, those social drinks, those drinks at dinner started to turn into a little bit more. It started turning into another glass of wine in the afternoon or 2 more glasses of wine in the evening. And we had to talk a lot about the potential of what could happen if she didn't really take a look at the fact that she's kind of switching over to a new addiction, to something different, to just change the way she's feeling and have her not feel. And she had never had a problem with alcohol, had never had blackouts, anything like that. But she started having this transition where she went from somebody who was just a normal social drinker to somebody who was having urges and started drinking more just to manage the anxiety and things that were going on. This is a lot of what is happening with our patients and with people who have eating disorders and the substance use. And here are just some of the statistics. So there's been a lot of research. These statistics are these are from about, I think, they're early 2000s, yet current research is showing that these are the same types of things. And actually from our standpoint, we know and we see people that, like it says, 50% of people with eating disorders use alcohol or illicit drugs. And then 36% of those people, or 35%, are more dependent, or who abused or were dependent on alcohol or drugs, have also had eating disorders. And personally, when we've seen people here, it seems like that number is even higher. And I think what happens is, with a lot of research, and like I said, even though there's research that's going on, there's still so much more to do. But just from what we see in our own patient population, that's numbers often much higher than that. And then you can see some of the other percentages of what we know about how often it co-occurs with anorexia, or co-occurs with binge eating disorder or bulimia. And you can see that bulimia is the highest percentage. So there is a lot of co-occurrence between substance use and bulimia. There's been a lot of research that's done. People have done PET scans, looked at the brain, looked at how the brain responds, and it does seem to have, bulimia has a very similar effect to drugs and alcohol on the brain. Okay. Are there any questions? Let's Okay. Okay. Also on this, you can see on this side, there's some of the drugs that co-occur that are common with eating disorders, and then a lot of the shared risk factors. So we'll be going over some of those things in the presentation. Okay, so drugs of choice. So basically at this point, it's almost anything that you can imagine, any drug is in some way helpful to a person with an eating disorder. Whether it's alcohol, alcohol just numbing, alcohol being this way to completely check out, disassociate, not feel. Like I said earlier, coke and meth, increasing metabolism, changing appetite, and also helping in weight loss. And then I mentioned earlier too about marijuana, what we see with people who are saying it helps give me hunger cues. I really want to eat. I just don't have any hunger cues and I don't feel like it. So I smoke to help with that. And then having people who smoke or use marijuana to help even aid in a binge. And then heroin and opiates, that's very common to help people when they're in this state with their eating disorder of, say for instance, there's these really strong hunger cues, like I really want to binge, or I'm really hungry, but I don't want to eat. And I can't stop that feeling and I can't suppress it. They're not going to use coke or meth, but heroin and opiates really suppress that feeling of wanting more and more of that angst, if that makes sense.
We do have a question.
Oh, good. Okay.
From Jean. She said she's worried about the legal use of marijuana and how that can be an easy reason to use it because it's okay.
That's a really good question, Jean. And we've come across a lot of that. So we'll have people who say, I've been using this for my anxiety. I've been using this because it helps with my eating disorder. And so your question of asking about legally what that means, and if people are able to get it and use it, we oftentimes find that is really inhibiting them from acknowledging and understanding that how that use, which may be just, oh, it's going to help me, it's anxiety, it's legal, but at the same time, what it's doing is it's affecting their eating disorder, and they're really getting stuck. They're not able to respond to treatment. They're not able to move forward because they still have this chemical that is numbing them, that is causing them to be detached, and essentially they're not really able to gain enough insight and understand what is going on with themselves and what is driving the behavior. So what we have to do is we have to say, we understand that you have, you're getting this is legal, but we do not allow or want anybody using any type of substances when they're in treatment with us at any level of care, because any type of substance is going to really distract, is going to cloud a person's ability to truly get in touch with the feelings, understand what triggers they have, and it's numbing. And we need to see, the trauma, we need to see the pain, we need to allow people to have these really uncomfortable, difficult feelings and walk through it and not have to use a substance or an eating disorder behavior to manage that discomfort. So thank you for that question. And one of the things that happens a lot is that part of eating disorder behavior and the compensatory behavior is about using laxatives or diuretics and diet pills. And it's common for someone to start out with just those types of things. Okay, I'm gonna go to the drugstore. I'm gonna buy some diet pills. That's normal. They're advertised. I can get them at the store. There's no big deal. What's the problem? And so all of a sudden the use of diet pills and maybe some diuretics in addition to it, that helped a little. But now the thought of, okay, this is not as effective as I'd like it to be, but I know that meth or cocaine is going to have maybe a similar effect, or Adderall, Ritalin, those types of things. So that can be, in a sense, like the gateway, a gateway drug to more illicit drugs that end up, of course, becoming a very addictive and very dangerous situation. We've had a lot of people. I've had a patient who she was taking 30, 40 diuretics, and then we 30, 40 laxatives at a time, just extreme. She ended up really ruining her kidneys and having major GI problems. The GI is a huge issue that we have with our patients. And when patients have been on laxatives or anything, even like the heroin and the opiates, which are constipating medications, they come in and their GI system isn't working. And it takes time. It takes time, and it takes a lot of medical intervention to help people's GI and even their kidneys, everything, to really respond to treatment after the damage that all these things can do. Okay, so there's a lot of things that are very similar, and a lot of things that people are finding out now, more so than they ever have, about how different areas of the brain are really affecting eating disorder and substance use. And so, I think a lot of people have heard and understand that the whole reward system in the brain is something that, that's affected by substances. And that drives so much of the substance use. And what happens with dopamine and just all of the neurotransmitters that are involved in the reward center. Well, eating disorder behaviors are very similar. And you can have that same type of reward feeling that many people feel from substances, from eating disorder behaviors. So it's restricting can do that. Over-exercising does it, binging does it, and even purging does it. All of those behaviors have the same effect on the reward pathway. But what happens is, after so much time and so much, let's say, manipulation of the reward center, and kind of just this overuse and abuse of the reward center, it becomes harder to feel or enjoy or find satisfaction from normal types of things. So if you work with people in the substance use field, I'm sure you see this quite often, that things, just normal things in life, don't have that same feeling, don't feel as good. Things are just kind of blah. And there's a lot of chemical and reasons why that does happen to the brain, and the eating disorders do the same thing. So we have times where someone may feel like, I'm not using my eating disorder, but I'm just not feeling a lot of enjoyment, or I'm not really feeling a lot of happiness. And so much of what has to happen in a recovery process is really learning and trying to find the things in life that will stimulate the reward system that aren't detrimental to the body. And those things are out there, but try and have someone who's got this eating disorder and substance use disorder be willing and open in understanding that human connection, connections with nature, connections with animals. There's so many different things that can make that and create that same feeling of joy and reward. And it doesn't only have to come from things that are detrimental. So also the brain, in an attempt to deal with sometimes pain, or to deal with psychological pain, there's these endogenous opioids that end up being produced. They are identical to the physiology and psychology of substance abuse in general, because what happens is a person feels their own opioids being stimulated and being released, and that actually ends up creating an addictive behavior, which is pretty much what I'm talking about, like with the behaviors mentioned: restricting, over-exercising, binging. So in those behaviors, you're creating these chemicals, and then all of a sudden that feeling, those chemicals that are naturally being released by the body, have then become something that is this stimulation for more of the addiction.
Okay. Someone did make a comment, kind of just off of that, it's hard to know what is what when there's so many, substances and behaviors being used.
Mm-hmm.
Like lack of fuel, alcohol-induced medication fog. It's hard to locate the healthy parts from underneath all the chemicals.
Yes. Yeah. That's absolutely the truth. And that's why when you're really looking at assessment and treatment, and in the assessment part, yeah, it is complicated because we have to really discern what's coming from what. And oftentimes it's not that clear. And sometimes it's not clear until there's a period of time with some, of some recovery. And when substances, eating disorder behaviors aren't active. One thing that is a very difficult part of eating disorder treatment is that and I'll kind of get into this in a little bit right now, but with the brain, the eating disorder is, if you're anorexic, if you're binging, purging, you're essentially damaging your brain, you're damaging, these different systems. We'll have people who have been malnourished, and restricting or whatever, who have purged and have this long-term malnourishment, and parts of the brain start to die. They start to become inactive. So one of the first things that we see happen with somebody who's malnourished is there's essential organ systems of their body that will just essentially stop. Women will stop getting their period. There will be a slowing of the heart. There will be changes in the gastrointestinal system because there's not enough calories, there's not enough energy coming in to actually allow these organ systems to operate. One of the big things that stops for somebody who is not getting enough nourishment is the frontal lobe. And that's the part of the brain that is responsible for insight and judgment, planning, all of those types of things. So we basically can have somebody who has a very diminished frontal lobe here, and we're trying to help them understand, help motivate them to realize they need to eat. But it's not working. And they're, despite how bad, despite how sick somebody becomes, even faced with just tangible information showing, like, look at your labs, look at your EKG, it still does not resonate. It still doesn't make sense. And we understand that because the brain is not working. I've had folks here who have said, yeah, I was in treatment for 30 days. I don't remember any of it. I've had a lot of folks that I've worked with who don't remember the treatment and what is going on. We essentially had to write everything down because they would not even be able to retain, understand, remember what was discussed. And it can be frustrating because a lot of people will say, well, they're not motivated, or they need to want this. And there's a lot of truth to that. Yet at the same time, it's important to really see how the medical complications of the patient with eating disorders can affect any type of psychological or emotional improvement. And a lot of that comes from the limbic system. The limbic system is really in charge and responsible for emotions. And with somebody who has an eating disorder, with somebody who's got substances, a substance use disorder, the impact on the limbic system is so much more intense than it would be otherwise. So I think a lot of people have heard and know that there's certain parts of the limbic system that it's been really clear. We know that the amygdala is responsible for that, for fear, for anger. A lot of times people with trauma, that amygdala starts firing and you start feeling that adrenaline, that fight, flight kind of feeling. And sometimes the amygdala can just be really drained and you get this let's say, overwhelming feeling of fear and anxiety that is not relevant to the situation. But then you don't have a frontal lobe to sit there and mediate that. The frontal lobe that can basically say, you know what, this is not as bad as it seems. This is not as dangerous as it seems. But with somebody who's got an eating disorder, somebody with substance use, that frontal lobe's not operating. So then it's just this overwhelming dumping amount of adrenaline and fear that folks are experiencing. There's also more information too about other parts of the brain now, the insula, that is showing more specific types of emotion that are involved in brain function. So this is all good news for us because it really does help in looking at how, medication-wise, or even just understanding how we treat, knowing what the brain is capable of somebody who is, under the use of any kind of substances or have an eating disorder. It's frustrating. Like I said, if you're a provider and you're trying to work with somebody and they're not responding to your treatment, and they seem to make some good strides one week, then the next week you feel like, okay, here we are doing this all over again. What do I do? And what we really try to help our folks and staff here understand is that you have to understand the medical and the physiological condition of the patient to be able to create a really useful treatment plan. Okay. Some other things of what's going on. So just talking about the insula again, it's not properly functioning. And the brain, like I said, like the frontal lobe will just go off and shut down. And so what that does is the insula is supposed to provide internal awareness, emotion, feelings, sensation, but more importantly, hunger. And a lot of people have looked at folks with anorexia and just, they don't feel hunger the same way. They don't taste food the same way. They don't get the reward of food the same way. And what that does in terms of how to complicate treatment can be very difficult, because if somebody does not like the taste of food because they're not having that same reaction, or on the other end, if somebody is having even an overreaction or a heightened response to food, you may see more binging behaviors. And then what happens again, that going back to that reward system. So the substances, those behaviors are going to cause the reward center, like I mentioned before, to hyperactivate. And then you're left with somebody who is essentially getting addicted to their own dopamine, to their own, their own adrenaline at times. And then eventually, somebody is not going to be able to enjoy just normal everyday life things. And it takes time. It takes a lot of treatment in order to have the brain really restore. Sometimes it takes a while. Sometimes it seems like it can be up to a year before that brain fog, that type of, just the type of insight that is needed to have sustained recovery comes back. It's not something that happens overnight. We see patients who have been malnourished for a long period of time. After a series of, a period of time with consistent nutrition and hydration, their organ systems start to function properly, but oftentimes they're left with medical problems, or they are left with an inability to really feel or express emotion or have a congruent emotion and reaction. So all of this is not something that is easily just repaired from some, a little bit of work. It takes time. And then a little bit more, with kind of going back to when I was describing what happens with the amygdala. And so when you've got somebody who has an eating disorder, and then you also see this with people with drug addiction who are in this constant state of fear of, what am I going to do? I don't want to eat. Or when am I going to get my next drink? Or when am I, I can't imagine walking up to a meal and sitting down and having to eat it. It's too much stress. I'm just going to walk away and go someplace else. Or somebody walking into a situation where they have to work and there's some stress in the job. They can't function. They can't handle it. Again, what's going on with the frontal lobe? It's not really working. It's not there to help mediate what's happening with the amygdala. And then all of a sudden, being able to just manage normal instinctual things like eating, taking care of oneself, ADLs aren't happening. And, it's this overdrive of the amygdala and what happens in the other areas of the brain because of it. And that includes, the hippocampus and other areas like the insula, like I've been mentioning, and what that means for somebody who is trying to find a way to regulate emotions, to just sit down and have a meal, and they're really struggling to do it. So at the bottom, I mentioned, and I talked about this a few minutes ago, what happens with the cortisol and the stress hormone. That starts getting released into the body. And so then that real feeling of stress and I can't be here, I can't do this, this is so overwhelming, these feelings are too much, I have to do something about it. Maybe somebody self-harms, maybe they go and relapse and use, maybe they purge. But it's a real challenge because what's happening in the brain is that, and what's interesting is the hippocampus, it starts to become smaller. And that affects, big thing is affecting memory, is affecting learning. And so when you have somebody who's operating with these deficiencies in their brain, based on the extreme use of either, both disorders, it's important to really change how you're assessing the patient, how you're treating the patient, what your expectations are of the patient and their progress. Okay. How am I on time? Let's see.
You're about 20 minutes
left.
Yeah.
Okay. All right. So kind of here's this picture of this is what happens, the fight, flight, or freeze, and you've got this cortisol in your body and these incredible just reactions. A lot of times the freezing part of, we see folks who they just shut down. They completely emotionally shut down. They dissociate. We have people that are dissociating at the table because the idea of eating is so overwhelming that they can't even be in their own skin. They run, they don't want to do it. They don't want to face it. They don't want to walk through it. Or there's a lot of resistance. And so if you think about what that's like managing somebody who's got two co-occurring disorders, somebody saying, okay, I can't eat, I can't deal with this, this is too much, I'm just going to go start drinking again. I'm going to start smoking again. The feelings are too much. It makes it very difficult as a therapist to be able to get underneath all of this stuff, really get underneath of what's driving these overwhelming emotions to help people to start working through those triggers and to really understand that these things can improve. And the way that you're perceiving it, the way you're feeling it in that moment is so intense, but it's not going to be like that. It's not going to be like that for the rest of your life. You're going to be able to manage and walk through pain and trauma and a lot of these things when your brain, when your body, and when you emotionally are in a place that you can regulate this insane reaction of what's going on in your brain to start really starting to feel some freedom and some peace. Okay. So big connections with substance use. We talked about the brain, talked about the similarities and the connections there. Same thing with personality. There's a lot of similarities in the personality traits. A lot of novelty seeking, impulsivity, very similar between bulimic patients and patients with substance use. There's a very, very strong correlation between those two disorders. And a lot of the, that impulsive behavior and not having the ability to slow down from that feeling of, I want to do this, I want to run, whatever it is, to let me make a different decision. Let me make a mindful decision about something, a rational decision about what to do next, the next right thing to do. And that's a very difficult thing that we see, of being able to give somebody enough tools so they can slow down, they can calm their brain, they can calm their amygdala enough to have a different perception, to be able to see things with a different set of eyes, essentially. There's a lot of sensitivity. We have, patients are often become therapists, become people in the field where they're helping. A lot of times just there's this amazing sensitivity. Unfortunately, it's not a positive thing, because we see people that just take on everybody else's issues as their own. They have a very difficult time separating out, this is not my stuff, this is not my problem. Somebody's upset, this person's angry, it must be because of something I've done. But it oftentimes has nothing to do with you. But there's this oversensitivity to interpersonal situations, and a friend is upset, it must be because of me. A parent is upset, it's something I did. People take too much responsibility for stuff that is not theirs to take. And we see that with substance and with eating disorders. Neuroticism, high levels of negative mood, depression, anxiety, low self-esteem. There, of course, so many different disorders, emotional disorders co-occur with eating disorders. I've never seen somebody who's just straight anorexic, straight bulimic without having depression or bipolar disorder or, schizoaffective disorder, anything. We see a lot of correlation between borderline personality disorder and eating disorder patients, much because of things that we're reviewing right now. And then poor emotion regulation, like I said, just, when you think about what they're dealing with, the cards they have in their hand, they've got a brain that is really not working, the frontal lobe's not effective, they've got an amygdala that's firing, and then how do I manage all of that overwhelming emotion and not have any tools to do it? And that becomes a very important part of how to treat these two disorders. Okay. Same shared risk factors, a lot of similarities. Trauma is a big one too. There's more and more, of course, incorporation of dealing with trauma in the eating disorder field, in substance use, and that's really getting, again, underneath the disorders, trying to figure out what's driving. It's not just about behavior, it's about the perception. It's about thinking about the emotional damage, the associations, the attachment that we have to traumatic, difficult situations in our life that keep replaying, and how that replaying of emotion, difficult emotion, is so intolerable that something has to be done to be able to deal with that. And then something that is really, unfortunately, just huge. And with adolescents, we're seeing now people younger and younger are getting eating disorders. So even kids that are 7, 8, 9, I was reading some research recently about how the kids that are starting, the really young children that are developing eating disorders and getting hospitalized for the disorders, a lot of that is coming from TV, social media, and a lot of modeling in the home. It's pretty alarming to think that a 7-year-old is at a point in their very young life where they can't stand the way they look, they can't stand the way they feel when they eat, or they're getting this reinforcement from what they're seeing on TV about what they should look like, about what's accepted. And that's unfortunately something that a lot of people in a lot of different treatment centers are having to open up places for the really young little ones. Social factors. And then you think about, okay, well, that's happening to those young children. We all know how we respond and how influenced and how in our faces all of that stuff is, whether we want to see it or not, it's all there. Okay. But again, we want to continue to treat the whole person. We understand that, like this little figure set, shows she's a culmination of a bunch of little puzzle pieces. And that's what this is. It's about, figuring out which piece, how do we put these pieces back together? How do we help a person to understand all of these parts of themselves, and how they are not, they're not damaged, that they are not fractured, that they can become whole again. And that takes time and it takes work, but it happens. And like, I think I've mentioned, this treatment is something that requires a lot of different interventions. It requires looking at medical, physical, spiritual, cognitive repairs and treatment, because we're dealing with so many different pieces of the puzzle for people. And it's not enough just to look at one section. Again, if we're just dealing with the psychiatric, but we're ignoring what is happening from a physiological standpoint, we may be missing and not treating effectively. So just some basic things that we, of course, do and that are necessary to be done in the course of treatment. And these are not easy feats. And a lot of time, somebody it may take days and days for somebody to be even able to drink fluid on a regular basis, eat some meals on a regular basis, making sure that there's not ongoing medical issues during that course of refeeding and hydration. But if there's not a containment of behaviors, if somebody is able to go into the bathroom and continue to purge every night, or they're able to binge, or they're just not eating and not having any fluid, which is a common thing too, there's a lot of damage that can be done. Something that's interesting is that we see, when we get patients that are coming into Montecatini, we require labs, and we require an EKG, among other things. And a lot of times we have people that are still, of course, in a lot of denial, and they come in and their labs are pretty good. And their way of basically saying, see, I'm not that sick, it's not that bad, is because, look, my labs are okay. What we often tell them is just give it a couple of weeks and your labs are probably going to become very abnormal very soon. The body is amazing. It goes into this homeostasis, it goes into this self-preservation, and essentially has to just prepare for not getting more calories or to lose calories or not getting hydration. And the organs are just in this essential emergency state of function. When people start eating and drinking normally again, then we start seeing labs become very abnormal, and the organ systems take time to start regulating again. But there's a lot of medications, especially the atypical antipsychotics, which have been incredibly helpful with our patients. This is something that we started seeing a long time ago, that the use of some of these atypical antipsychotics can stop that ruminating thinking, can stop that spinning in the mind in a way that other SSRIs or other medications can't do. And that can be a real help to somebody's treatment. But of course, it's very different based on the disorder, where they are in terms of nourishment, what they're able to deal with in terms of the side effects and things like that. So it doesn't necessarily work for all people. There's a lot of indications of how to and what kinds of medications to use it with different types of eating disorders. So the thing that is really effective, though, is that these medications, of course, are also affecting a lot of those same types of feelings and triggers that cause somebody to go out and drink and use too. And then our dietary approach. I think it's interesting. There's a lot of people who have been in substance use treatment, or a big part of just treating substance use is getting and feeling healthy again. I've been drinking for so long and I haven't been eating. I'm getting sick. I'm having problems with my liver. And it's, I'm going to start eating. I'm just going to start exercising. I'm going to start, making sure I'm not eating bad foods. And in that effort, for somebody who's really trying to just physically recover from substance use, can find themselves feeling again like, wow, maybe this exercising, maybe this eating healthy is now becoming a little bit more of an obsession. Again, like I said earlier, maybe somebody's now going from running 1 mile to 5 miles. And then before you know it, it's, if I don't do those things, if I don't run, then I'm not going to be able to be okay in my own skin. My anxiety is going to get too high. So here, we talk about balance, moderation, and variety, and we work from a standpoint of health at every size, which basically means that, we're not promoting weight loss. We're not saying that you'll feel better if you need to lose weight. You need to, you're not going to be healthy until you are this size. That is something that is very detrimental thing when, and people even who are coming into with any kind of recovery, that they're not going to be okay. They're not going to be able to be healthy if they are not thin. So we have an approach in how we deal with those types of things in people's meal plans when they're here for treatment. Okay, and then physical activity, just kind of what I'm talking about. It's at Montecatini, we look at physical activity in different ways, not like what typical people, I think, will see. It's not always like, I need to exercise more. A lot of our folks are, they become obsessed and they over-exercise, but a lot of them also are completely avoidant of exercise. They don't want to feel anything. They don't want to feel what it's like to move in their own body. People need a lot of work sometimes on just learning how to enjoy moving rather than it becoming this means to an end. Find a new relationship with food, but I also need to find this new relationship with exercise, and how it's affecting my recovery in my life. And then the cognitive, emotional, the basic stuff, the stuff that we know that works. There's CBT and DBT. We talk a lot about here, though. We talk a lot about attachment and what that's like, and the attachment that we have, and the attachment injuries that have occurred our lives that have oftentimes reinforced these core beliefs that people have. I'm not lovable. I'm not going to get better. I'm damaged. There's really challenging those beliefs and where those came from, and in their stage of life, of how that became part of their belief system. And we have something that we really work from, which is called our integrated care model. And essentially what that means and what that does is we're taking a lot of the same principles, even from 12 steps. We're taking a lot of these ideas about denial and surrender and these principles of what are effective and what are important of understanding about oneself when they're going through any type of substance use treatment. But for eating disorders, it's the same thing. It's these shared belief systems. There's this, the denial that our folks live in, the amount of, I'm not able to surrender this. I'm not able to give this up yet. I can give up my eating disorder, but I can't stop smoking, or vice versa. But we challenge those beliefs. We challenge those ideas of why we're holding on to those, how to let go of those. Are those healthy? And it can be hard because, like I said earlier, if you're dealing with somebody whose brain is not really 100% functional, trying to have the insight and awareness to do some of these things is difficult. And then spiritual mindfulness. So much of being able to calm yourself down, to be able to slow that amygdala and the response and the fear, can be just taking a deep breath, by changing your focus, walking outside, changing environment. There's a lot of just small, basic types of skills and interventions that can really work to help slow the amount of the time between the trigger and the response. So things like, we try to help people start to identify how meditation can help do that, how yoga, different types of practices can do that for them, breathing. And when people are able to just slow the amygdala down, all of a sudden there's a clarity, there's a different perspective. But this is, oftentimes our clinical director will say, this is a disease of disconnection. And the thing that I know and see with the folks that we treat, they don't get maybe that same intense reward system they did from doing a line of Coke or purging or binging. But the thing that always motivates, I always find the people that who have done well and who have been successful have been really able to refocus on the things that matter. So when I was talking earlier about the former patients that I treated, and a lot of their challenges that they had in recovery, the one thing that I was finally able to help get through and help them connect to was that they wanted more than anything to have a feeling of human connection again. At first, that was not an issue. They had no desire, but little by little, they started realizing what they were trying to find with eating disorders and drugs was a connection. They were trying to use their voice. And when that didn't work, they just went completely inward. Little by little, I see people who have become reconnected with family, have become connected with peers, have become connected with their environment. And then all of a sudden you see these patients change and start seeing them react to the reward of what that emotion feels like when they're with somebody that they care about or somebody that they love. And really, that's the key. That's the key to recovery. And it's an amazing thing as a therapist, as somebody, working here at Montecatini, that we get to see how those things change and see how those repairs, those attachment repairs, can really affect ongoing and long-term recovery. And yes, a lot of people say, I'm never going to be able to recover from both, but you can. I did. And I let the folks here that I've worked with and people that I know realize that you can recover from both. It's possible. And there's hope. There's always hope. We hold hope for our people here. And fortunately, we've had a lot of success, and we've seen people come through the other side and find that they don't need substances, or they don't need an eating disorder to manage their anxiety, to deal with life, that they can walk through difficulty and pain and recover and be okay. And that's all the slides that I have. Thank you guys for letting me present. I don't know if there's some other questions out there. Emily, do you see any other questions or comments?
If there's any questions, if anybody wants to unmute themselves and ask, you're definitely free to do that. If not, then we can conclude. Oh, there's one question.
Okay.
Sorry, let me see. Why did the first case study you talked about come back 3 times?
That's a good question. So there's a lot of recidivism in eating disorder treatment. It's one of these things where I think what's hard is that people don't realize that, it's not like substances where you can just stop drinking and using. But it's when you eat, you have to eat every single day. It's not something you can abstain from. So with her, she came in the first time, she had that level of just denial. The second time, she was a little bit more open to it. The third time, she had really hit a bottom with both. She had hit a bottom with drinking. She had hit a bottom with her eating disorder, and physically, emotionally, she started getting worse. Her symptoms got worse, and she ended up in the hospital for quite a long time with some serious medical problems. Even after that, she was still in somewhat denial that she had a problem. But little by little, I think all the work that we did finally hit, because she now recognizes that she has to stay sober in order to have her recovery from eating disorders. And she's actually in college becoming a therapist right now. So it was a long road. It was a hard road of admitting and accepting, but the times in treatment helped her evolve to that thinking. So. Any other questions?
There's one more. She said, would you recommend focusing on the eating disorder first before the substance abuse, or vice versa, in the case of acute and behaviors and or substance abuse? Oh, sorry, acute eating disorder behaviors.
Yeah, and that's a good question. So when we have the ability to do some. We have patients that come in who have been actively using. We do have patients that need to go into detox in a hospital or type of specific detox setting before they can come in. But the problem is that, with either acute eating disorder or acute substance, it's easy to start switching over to a new behavior if there's not this kind of concurrent treatment. The recommendation is that if somebody's having an acute eating disorder type of, like, say for instance, they're highly malnourished, they're potentially going into some sort of refeeding syndrome, the beginning of eating disorder treatment of that nature is all about medical stabilization. And so I think what's helpful, if you can have a place that can really manage a certain amount of the acuity of both of those disorders, that's ideal. But yes, sometimes somebody has to go, deal with acute eating disorder symptoms first, or vice versa. But the hope is once that immediate need is, or that immediate urgency is stabilized, then treatment can continue for both disorders.
Yeah, and somebody else made a comment kind of going off of that, that eating disorder centers often say to take care of the substance abuse first, but substance abuse centers often say they can't deal with the eating disorder.
Yeah, exactly. That's one of the things that really drove me here at Monogatini to change the way that we treat in our program, because, this has been historically a big problem, and patients are going back and forth. And if you can think about what it's like to go into one treatment center, then go into another, people start feeling defeated. They don't want to continue to work. They've worked on their substance use. I've been in treatment for 30 days. I don't want to go back to treatment. I don't want to do RTC any longer. And there are a lot of treatment centers for eating disorders that will not deal with people with substances. And with substance use treatments, it's a positive thing, though, too, that people are really recognizing in substance use treatment that if somebody's got an eating disorder, there can be a very, very dangerous patient. A lot of times what we'll say is you need to check labs, you need to look at these things. And so people are, I think, becoming more cautious with some of these folks. And I think it's about finding the places and finding the people who are capable of managing both of those people, because otherwise, what I notice and what I see just in the field is there's more and more treatment centers finally realizing that concurrent treatment is key. These things can't happen, going back and forth and one after the other. So concurrent treatment is optimal. Unfortunately, it's not always easy to find a place that's willing to take a patient that has those types of symptoms.